So thanks everybody for joining us. This is a panel discussion about fairness in artificial intelligence. How can we avoid bias and disparities in orthopedic applications of artificial intelligence? That was published in the Journal of Orthopedic Experience and Innovation. And we'd like to thank Zimmer Biomet for their assistance in this as well. If you have a chance to look in the chat, I placed the link and the title of the article in the chat. So if you want to pull that up while you're waiting, you can do that. And then we will ask that if you have any questions, please put them in the chat section, and then we'll call on you during the session to actually verbally walk us through your question or your comment, and then the panel and the group can respond accordingly. So if you haven't had a chance, like I said, I put the link in the chat box for the article, so you can go online and have it up while you're watching. So today what we'd like to do is discuss with Atul and his group, how do we manage artificial intelligence and the health disparities associated with that? I'm in Southern Louisiana. We've got a fair amount of inequities and health disparities here. And one of the challenges I think moving forward for us is, how do we handle this technology or kind of technologies in general in a underserved or marginalized patient populations? And I think Atul's got a few papers and research in this space. We've got a couple in this space as well, and it's definitely a challenge. So, I'll turn it over to Atul. Maybe your group can introduce yourselves, the authors, and then tell us a little bit more about the paper. Why now? Why this particular topic? There's a number of technologies we could talk about. Why particularly this? And then kind of where you think things are heading.
Yeah, thanks. To the group there, my name is Atul Kamath. I work in Cleveland at Cleveland Clinic. I do hip and knee replacement, I do some young hip surgery. Our research group is very active in multiple fronts, including machine learning and these types of kind of melding different technologies and getting data on the front end, processing it, intraoperative execution. So this topic is really rapidly changing and really trying to understand it from multiple perspectives. And from my standpoint, really lending this kind of clinical lens to some of the really thoughtful science behind this particular paper and behind the kind of field itself. And I would say really thank the Journal of Orthopedic Experience and Innovation for providing this forum. This topic, as it was billed in some of the kind of preamble to the meeting, is controversial. And this topic needs a lot more development. But JOEI, really took this upon themselves to say, really found an interest in this particular topic, where some of the mainstream or other types of journals that are more traditionally kind of, conservative in terms of some of their views, really had some questions about sort of, how do we develop this topic? Where does this commentary go? So really appreciate this forum, really appreciate the discussion that we're going to have tonight and the opportunity. So I'll turn it over to the co-authors, Carl and Dave there, if you want to introduce themselves.
Great, thank you. Thanks, Dr. Kamath. Yeah, so hi everyone. My name's Carl Sermax. I'm part of the team that's authored this paper. I work at Zimmer Biomet as a lead data scientist there. My interest in this topic comes, I guess, well, from a data perspective, but also, I've come to work in in healthcare applications during my career, having started outside of healthcare. And I think the question about sort of why now for this paper and to start talking about this, I think coming to healthcare from the outside, I think healthcare is actually, in a really good place to start addressing this topic for reasons which I think hopefully we'll get onto and discuss. I think, as we talked about in the paper, other industries have had a go at implementing this technology and maybe sort of made some mistakes along the way. So I think we're in a really good place to be able to sort of learn from sort of some of those past experiences and really sort of adopt these technologies in the right way. So really looking forward to discussing this more. And just want to extend my thanks to the JOEI for inviting us. With that, I'll hand over to Dave.
Yeah, thanks, Carl. I'm Dave Van Andel. I'm the Director of Clinical Strategy for Zimmer Biomet here, kind of working with Carl and the team on our data and AI projects. And so my role here is really kind of making sure that the experts are connected to the clinical experts, like Dr. Camus on this. And yeah, we're as a company, we're very interested in AI. As many companies have been over the last 4 or 5 years, we've been increasing our DEI interests as well. Zimmer Biomet is very conscious of the diversity that we, as a group and as a company, from an orthopedics perspective, haven't had historically, and so it's been a very active place for us, looking at all aspects of our DEI initiatives. And so it just goes to kind of a very base level that we have to start thinking about that from our products, and especially in a product like this. I think Dr. Kirschenbaum was kind enough to stir the pot a little bit and mention some of the controversial aspects of AI. And I think we understand some of that. I think it's not going to be a complete home run every time you step out onto the field, right? So. But this is a topic that was important for us to start working with and working through as a group, and we really wanted to invite the industry and really the orthopedics as a whole into the conversation. So super privileged to be here tonight discussing it, and really excited to have some feedback.
Great, thanks, guys. Just as a reminder to all our listeners, I put the link to the article in the chat. So if you want to click on that, you can reference the paper while we're talking. If you have any questions or comments, please put them in the chat, and then we'll ask you to unmute yourself and actually ask the questions to the group, and so that way we can have a little dialogue. So let me kind of start this off, and to the authors, the challenge is the data. It's kind of garbage in, garbage out. And from a health disparities perspective, how do you think the data that we have, what do you think about the quality of the data that exists before we start analyzing it and start running it through algorithms and all that kind of stuff? So at the baseline, how are we with data capture? How is the quality of the data? What's the fidelity of the data, in your opinion, as it relates to this paper?
Yeah, I'll take a stab first, and then Carl will really kind of lean in on kind of the science behind it and really bring that kind of objective perspective. But Vinod, that, as you know, I mean, we are beholden to some of the very traditional metrics that we have been doing in orthopedics for the last 100+ years. I mean, we have things like X-rays, we have physical examination. I saw a post from you earlier today, maybe even or this week, on one of the doc social groups on, basic X-ray where there's severe arthritis, but the patient is kind of just trucking along, has really no pain. I mean, but there's more to the story than we have from our traditional measures of what orthopedic data can provide for us. So I would say we've leaned, to be fair or unfair to our research, community. We've leaned too much on some of these kind of historical metrics, and we need to be pushing those boundaries. Now, the question on data pieces, it's what you can pull in, right? And it's the amount of data and how you can process it. So even simple things like understanding the correlation between radiographic arthritis and clinical outcomes or clinical utility or costs or sort of care that's delivered. I mean, we have trouble to kind of sometimes even meet those simple kind of data points. So, to your point, I think we've really used some really historical metrics. We need to start bringing in the bigger picture. We need to get more objective data rather than subjective opinions. And I think we've also been going very much from the clinician standpoint, rather than, really weaving in what the patients are telling us and how that patient perspective gets pushed forward. So multiple areas where we have fallen short as a community on gathering meaningful data, understanding that data and processing it, and then also importantly, translating it to outcomes. So lots of opportunity to improve on that. And then lots of avenues to start innovating and looking for ways to link data points and link the ways we capture that data. So.
Great. Carl, I mean, from a data capture perspective, what are the challenges you've got? I mean, our data scientists, it's pretty dirty when the data hits our computers. and to normalize it and do all the things that you need to do to make it workable. I mean, that's not easy. And there's bias just in that, right? Just even cleaning it up can create a lot of issues.
Yeah, agreed. And I think one of the challenges that we grapple with is how exactly that data is collected, and the influence that will have on on, as you mentioned, the characteristics of that data. To what extent can we rely on patients to provide information about their experience, their recovery, even documenting their any comorbidities or sort of past medical history going into a procedure. So yeah, I think there's a trade-off between how the different sources, different ways that we collect that data, and we can kind of enforce, or we can kind of specify cleanliness, but then we lose some of the richness along the way. So yeah, and I think that just to do the other discussion as well, I think we are sort of getting better at capturing some of those objective measures and understanding patient recovery through technologies such as wearable sort of phones, those that are capturing information about patient movement and so on. And the challenge is really, as I think, as Dr. Kameth was saying, is linking those things back to those traditional outcomes, so we can say with confidence that those are representing sort of meaningful metrics.
Yeah, just to jump on that, I mean, there's a tremendous amount of noise, so to speak, in the data as you bring up the note, right? And so another traditional metric, step count, or how many feet can they walk in a certain amount of time from post-surgery. But what really changed a little bit of my frame on this whole question is some of the piece, and we'll perhaps get into it with, Walk AI, Zimmer Biomet's model for early recovery here. But when I started looking at some of these curves, when it said, okay, it's not just how many steps or how much distance they've covered, but it's really a gait quality, or are they really meeting their milestones on gait quality? Now we're taking just volumes of data and we're really starting to reference it, starting to scrub it, starting to clean it. And Carl can probably, and Dave can probably get into how that process gets about from the 30,000 foot view. But now we're taking lots of noise and data that's kind of a little confusing, or even metrics that we don't really have any benchmarks to relate to. And then starting to say, well, yes, actually this person is walking 10,000 steps, but their quality of the gait is very poor. Now we have some sort of kind of measurable understanding that you or I in clinic, when that patient's walking towards us in the exam room, you can say, well, that gait's pretty good. Or, what, that gait is just not great. But now we have ways to, again, scrub the data, understand it, test it in the models, and then apply it, to really start to understand what that means from just simple historical metrics to really sort of understanding how that patient is moving. And that's just one parameter that I think we can probably talk about or get into a little bit. But that really kind of changed my frame of reference on this whole question of what is meaningful data and how we scrub it and how do we really translate that into clinical questions.
Yeah, no, I agree. Dave, what's your take on this? I mean, how do we interpret this? This is not easy to get our hands around because, right now I'm a surgeon, your incision looks good, your flexion is this, you say you're doing well, I'm done, right?
Right. No, I think that, outcomes are, we're currently grappling with outcomes kind of across the board, trying to figure out exactly how much weight to put in what outcomes. Dr. Kameth mentions the gait quality as another layer of this, right? So it's not just a PROM score or a particular question on a PROM. It's not a satisfaction score. It can be a qualitative measurement of patient's gait. But I would say that when we start to choose those outcomes, there's value in every data point you select, right? So you place a value in a hierarchy on kind of where that data point lies in the value of the procedure and the outcome. And so, we have to be careful in looking at these outcomes to really find ways to match that up with what the patients are coming to the table looking for, right? And I think those are studies that have obviously have a long history in orthopedics, looking at patient expectations and things like that. Finding ways for us, in the product side for Zimmer Biomet, from the data collection standpoint, finding ways to easily and quickly capture that, and make sure that, to your point, that it's a clean data point and that patients are, reporting that the way that we would like to see that reported, and then matching that up to the postoperative outcomes. All those things are a challenge because, in some sense, they're a little different for every patient population, and we have to be sensitive to how we collect that. So, it's a challenging question. It's challenging sometimes just to think through the valuation of these data points as we think about it.
I think, Vinod, you kind of bring up the question of again, we have been beholden to more kind of static pictures of data in the past, right? And now we need to start looking at sort of dynamic or updating models. We can't simply publish a paper on, particular gait quality without having the follow-up to understand and kind of get that feedback loop. So that continuous feedback, the dynamic nature of interacting with the data, is that constant scrubbing of the data and that constant kind of evolution. So I think, AI, and this is just, we're not even talking about fairness yet, but AI in general, a critical aspect of how we need to start. If a group or a company or a vendor is putting out data like this, they have to have the resources to start updating their models over time and continually refining this. It's an obligation to doing that, because simply saying that there is signal to noise at a certain point, that has to be fine-tuned with time. And so it's a huge resource intensive thing. And I think, but again, this is a key point that I think needs to be brought out in the just AI discussion in general.
So in your paper, you guys talk about, you had a couple of use cases and where disparities may impact outcomes. And one of them was, predicting who's going to do well or who deserves surgery or who should have surgery or what have you. But right now, it seems like the focus is not necessarily kind of upstream. Everyone's trying to do wearables and AI in terms of postoperative function and recovery and stuff like that. But your paper seems to focus a lot. Can we understand who's going to do well and why and how and when and all that kind of stuff? So where is AI most useful right now? Is it upstream before the surgery and disease management, or is it downstream after surgery and trying to understand why patients aren't doing well? Did we put our implants in the wrong way or upside down or what have you? Where do I start? How do I get my hands around this?
Yeah, my clinical take, and I think, if you wanted to, I think we could even go through some of those use cases of kind of pearls and pitfalls. And I know Carl can really weigh in on that. But, really my take is, as powerful as we can be on the front end, I think this is going to be important, right, for resource utilization, for really selecting the right patients to then have better outcomes, I think, on the front end. But to your point, the front end models are only as good as the back end data that comes out of it, right? This feedback loop. So I would love to see these become very powerful on the preoperative side and then really link it to well done surgery. But again, it's just the picture is never complete until we have that, until we're sort of looking at from the back end, and some of the implants and techniques and kind of data stuff that now we have the ability to go to 10, 20 years post-operatively. These are pretty powerful loops. And if I do my job right on the preoperative end and I know my intraoperative execution is good, to your point, if someone's doing well and they meet all their milestones and they're growing up well, I may never need to see them again, type of thing. So while we can continue to sort of passively collect all their data on the back end. So I don't know where the most eggs need to go in the basket, but my bias, at least from, where we're going, is, the preoperative end is so critical. Now, Carl and Dave may have a difference of opinion, and you might to say, well, the back end, really robust back end in the postoperative period is where we actually know what we're doing is working, right? So that may be just as critical, or you may not be able to even choose which part of the equation needs to be further developed. Carl, you'll correct me right now. Tell us what we need. Tell us where the most money is, so to speak.
Well, I'm not sure about where the money is, but I believe that sort of AI and machine learning can support across the episode of care. Really sort of supporting decisions. Wherever data can do that. So whether it's sorry, it's just a bit of feedback on the line. Yeah. So whether it's kind of supporting decisions that are made, preoperatively. I think we've talked a bit about the differences between patients. Patient expectations is a really interesting area where I think data can support even sort of the pre-op, in the pre-op phase of understanding, what's are expectations misaligned in terms of recovery, or can data support those early discussions? We've talked about pre-op, I think, because post-op, because we were talking about outcomes. But yeah, I think even sort of in the intra-op sort of planning, so how can you combine data from preoperative imaging and then data that's collected in the OR through some of the robotics technology as well. So I do think it can support across the episode of care. Now I think we have to think about like a stepwise approach to get there. I think some of those use cases that I touched on are more complex and more difficult to achieve than others. So I think it's going to be a kind of iterative process to sort of build out across that episode of care.
Dave, this is going to be a long haul, right? This is not, we're going to need, I probably don't know how many zeros of terabytes of data that we're going to need to have anything meaningful. I mean, what's the time frame here? Are we talking about when my great grandchildren are, adults, or is this something I'm going to have to react and deal with in my career?
Yeah, it's a good question. I think, it depends on the solution that we're talking about. As kind of hearkening back to the prior question, there's inherent risk in deciding how to use AI for different solutions. And if you think about the risk associated with telling a patient, they can or can't have surgery, or they're, associating a risk for the surgery with them preoperatively. The feedback loops with surgeon suggestion and patient performance can get pretty mixed. And so you could actually start to influence, even with that type of an AI product, you could influence the outcome negatively just by putting that type of a story in the patient's head, right? So I think, as we think about what products are going to come forward with AI, we're going to probably want to take a fairly tactful approach and start with low-risk products. Some of the things that we're talking about, maybe predicting some outcome. Walk AI, for example, our first product from Zimmer Biomet, has a prediction associated with a 90-day outcome relative to the gait quality. And those kind of predictions, when shown to a surgeon or a care team, are fairly low risk, because you don't necessarily have it flash in front of the patient. You don't necessarily show the patient, hey, you're doing poorly or anything like that. But we start with these kind of lower risk products and start to move into more influential products as we go along. Vinod, I'm not sure how to answer your question. It probably depends a little bit on what the product is that we're talking about. I think AI will be fairly embedded into the system by the time your grandkids come along. I don't know your exact age, but I'm suspecting that we're probably going to have quite a few things that are going to be. I'm assuming so, but we'll probably have quite a few AI products well down the road and in use. But relative to the risk associated with those products, we'll probably have some starter products that are fairly low risk to start, and then moving into the more regulated space. And the FDA has certainly come out and said some things about this. That was also included in the paper too. So that's going to start to shape these the products and how quickly these things come about, and the influence.
I think it's going to be some of the appetite from patients too, in the adoption and their ability, right? So, we ran a MyMobility, and we're continuing to run MyMobility study here in the clinic. And I was surprised sometimes at the how facile some of these 80-year-olds are with their smartphone, right? And they're really into the technology. They're kind of very proactive with that. I think that helps accelerate a lot of what we're talking about. I think a lot of the computing end is also going to help us to kind of a lot of process this data. So, I don't think it's your great-grandchildren, Vinod, but I think certainly the next decade is certainly really developing a lot of this, testing it out. And then I think as patients, and I think really you got to put that perspective at front, when patients are starting to understand this, some of the big data behind what we're looking at here, folks drive their Teslas, and, Teslas are really data gathering machines on wheels rather than sort of automotive point A to point B type stuff. I mean, it's a huge data type piece. And I think as lay community, as well as physicians and providers can understand this, and then also as a community, we can pay for a lot of this. I think that's where some of this adoption will either go more rapidly or slowly, depending on some of those phases of adoption. So,
Carl, when you grab the data from all these different locations, I mean, how are you are you able to clean this up in a way and normalize it that you can really compare Cleveland Clinic to Vanderbilt to Seattle to Chicago?
Yeah, and it ties to the topic of the fairness and how you evaluate, how you can evaluate models for fairness is looking at whether these models do generalize to generalize across clinics, across even across regions. So the data set that we're working with and we're sort of using to train and validate our products is a global data set. So across Americas, APAC, EMEA mainly. We do see regional variations, and we're able to take some of those into account. Yeah, and I think part of that also comes down to the getting specific about how we frame the problem. What's our outcome of interest? Dave mentioned that we're looking at benchmarking patients, or at least kind of measuring their outcome relative to where they were pre-op, which helps with some of that as well. So you can account for some of that variability by being sort of thoughtful about how you define an outcome and how you estimate it.
Got it. I appreciate it. So we're coming up about the halfway point. I want to turn it over to Mike Anderson for a few minutes from Zimmer Biomet to tell us a little bit about what they're working on. Then as soon as he's done, we'll come back and I'm going to start prodding a little bit harder here, and we're going to start talking about health disparities and inequities, and is Carl really being fair and just as he analyzes?
Thanks, Dr. Doss. I appreciate it. We just have a little bit of video here to show what we're doing as a company in AI, and hopefully how this will affect patients in the future. That's the direction we want to go, is to improve outcomes. And so I'm just going to share this with you, and we'll get back to the discussion. All right.
Mike, I don't know if there's sound. Do you want to enable the sound from the options?
No sound on it?
Yeah.
That's not good.
If you go to the options, and there should be a thing that says share sound, or
there it is. All right, let's try that.
There we go. It's working.
Today, I am excited and proud to share that Zimmer Biomet is releasing the first near real-time predictive model for the orthopedic industry, the byproduct of our proprietary database of clinically relevant information and artificial intelligence. Introducing Walk AI. Walk AI marks the first feature release on the ZB Edge platform that brings dynamic episode of care data together with AI, allowing you to know before it shows by bringing you notifications from the future. Simply put, Walk AI identifies patients who are predicted to have a lower gait speed outcome at 90 days after hip and knee surgery. Here's how it works. Before surgery, the Walk AI model establishes the patient cohort based off of procedure type, patient medical history, and the patient's mobility and gait metrics. Then, from day 15 to day 40 after surgery, Walk AI uses a proprietary algorithm to analyze a patient's mobility to generate a personalized daily prediction of their gait speed at 90 days post-operation. The daily prediction is compared to outcomes of a matched cohort of aggregated and anonymized mobility data from the extensive ZB Edge patient database to identify when a patient's recovery may not be on track and requires attention. If a patient's gait speed is in the bottom 15th percentile compared to their matched cohort, an exception and care team notification are triggered.
I've thought for a long time one of the big challenges in orthopedics is the black hole. The patients leave your hospital, you've done a lovely knee replacement or hip replacement, and then you don't know what happens to them. You don't know because they're gone for 6 weeks before you see them in the outpatients again later. If you're notified that they're struggling in some way through this model, you can then contact them early, and you then have the ability to treat them early with a greater success rate. The thing that most excites me about now applications of artificial intelligence, particularly through my mobility and the Walk AI, is what I call a feedback loop now from data collected during surgery with the robot, operative decisions made to the nearest 1 degree, to the nearest 1 millimeter, then having objective digitally collected data on how well the patients do day after day, week after week, which we simply did not have before. We used to rely on 12-question questionnaires at 3 months and 6 months to discriminate who was doing well and who wasn't. This interpretation, this artificial intelligence, this objectively collected patient performance is helping me do the best for my patients, knowing that those decisions, those micro decisions I make during surgery, all amount to the best result for them. Prior to this, they were based on feel, based on my analog interpretation of results. Now they can be based on science, data, analysis of data that I couldn't interpret but that AI can, and it feedback loops to those messages that just mean that I can be confident, sleep well at night, I often call it, surgeons do, they want to sleep well at night, knowing that they've done their best for their patient.
All right, thanks, Dr. Dasa. It's important for us to hopefully get more improvements in healthcare before your great-grandkids. But it all starts with collecting data, and that's one of our missions here at Zimmer Biomet, is to be able to have a database that we can do these things with. So I'll turn the time back over to you.
Great. Thanks, Mike. So just a reminder to all the participants, if you have any questions, please put them in the chat, and then we'll have you ask them and have the panelists answer them. So let's kind of push forward a little bit, and let's start talking about health disparities and inequities. I've got a patient, I'm in Southern Louisiana, Gulf Coast. We've got health disparities like anybody. We're probably the definition of that down here in terms of inequities. I've got HSS, the Ivory Tower in Manhattan. I think they had a paper recently they published in the last couple of years, 95% of the patients were Caucasian, right? And that's not reality, but those are the benchmarks. Those are the outcomes now that I'm benchmarked against. I've got a patient this week who doesn't speak Spanish, who doesn't speak English, and doesn't use a computer. So tell me, how is AI going to make sure that non-English speaking, non-technology using patient, if you will, is going to be treated fairly in these algorithms? If we're using data out of HSS, and no offense at all, data out of Cleveland Clinic and Stanford and all these other places.
Yeah, I think from our perspective, it's a challenging question. I think the heart of what we'll get discussing here, and I think there's multiple topics here. There's socioeconomic status. There are different indices of how we rate patients in terms of deprivation indices. And then there are other kind of allied topics like social determinants of health, which is a huge buzzword right now, but really the opportunity to really understand, a lot of these are covariates when we look at the data, right? And I think, Carl will kind of educate us on how that is treated from a statistical perspective. But the idea is to, if you have a large biased Caucasian data set out of HSS, for example, or the Cleveland Clinic, certainly our data is not 95% Caucasian. It's more of a mixture for sure. But taking those and using the data to then start minimizing or understanding what the covariates are, right? And then instead of, and it's also, so that's one piece to understand those covariates. The second piece is then to start asking the right questions, right? And I think that's where going through some of the use cases and how the data is applied is extremely critical, right? So I think if we were to look at that particular subset, a very disadvantaged, for example, patient down in Louisiana, we really have to understand how that group is protected within the data, and how do we balance, again, things like their social determinants with other factors like socioeconomic status that might just get pulled off a zip code or pulled off something else to that effect. So that's kind of the big picture in terms of understanding, getting the data, and that's why we're using this large data to start minimizing those differences. But then also understanding, again, from the patient's perspective, how they fall into those groups of the kind of the covariates that we're talking about here. So, but Carl, your thoughts, and Dave as well.
Yeah, I think thinking about the question, it's I don't know if there's an easy answer to this one. I think machine learning models will, they're very good at discovering the trends and discovering the patterns that are there in the data set that's being collected. And I think it's on us as practitioners to make sure that the models that we're building, that they are being applied in sort of in appropriate scenarios. One of the big things that we look at in our model development and validation is and this, I guess, the cornerstone of machine learning is does your model apply to or does it work equally well or sort of similarly well on the data set that it hasn't seen before? So if that data set that you're running your models on is very different, then you do have to be very careful. I think the impact of that, comes down to the use case. So this is kind of what we highlight in the paper, is that if it's one thing to for a patient from like from a different socioeconomic background, if a notification is sent to their clinician to say, you might want to keep an eye on this patient, versus an algorithm that's guiding in terms of like decisions around that care and treatments. So that's where the kind of the fairness and sort of some of those potentially sort of harmful feedback loops can come in. But yeah, I think it's on us as developers of these models to make sure that that diversity of data is diversity of population is represented in the data, and that we're the models are being used appropriately. And I know, Dave, we talk a bit about this in terms of ways that we can enhance that in our own data set as well.
Yeah, I mean, unfortunately, if we think about how data sets are built, at least in the Zimmer Biomet ecosystem, smartphone is kind of a barrier for entry, right? You have to have the smartphone as an application to start, and those, fortunately, there's a lot of communities where it's fairly ubiquitous. It's in a lot of situations, it's the only connection to the internet that many patients may have. But there's still those places, and you mentioned it, Vinod, as well. Those places where that's not the case. I think the other place that we think about is clinical trials, and again, that those communities tend to be underrepresented in our clinical trials as well. And it's not an easy solution to try to just go after and find those patients and be able to enlist them in clinical trials. They're just not likely to participate at the same rates as the other patients that are more represented in our databases. So Carl and I spend many a meeting thinking through what are the ways that we can expand these types of data collection points, and it's a real problem.
Go ahead, Atul.
No, Russell in the chat has some good comments here. Maybe we'll get to as well. But I think it also gets to the question of really, it's our obligation, from clinician standpoint, to be vocal as we go through this, and then also as we interface with industry or even in our institutional type registries, in-house data, and then in the larger communities to really start teasing out, looking for the patients at most risk for sort of poorer outcomes. And we have qualitative fields like you're talking about here. I have patients of the same kind of risk for a poorer outcome or poor social support. We need to really understand that and kind of keep feeding that back into our models. So we have digital twins that now we're starting to build across different sites and start to keep referencing that and understand that as well. And the same disadvantaged patient that may walk through the door in New York City or may walk through the door in Cleveland, there are other factors that now start influencing that, the ability of that health system to then identify or poor resources that are appropriate to optimize that patient. And I think understanding that over time is critical, because that's, again, of the other back piece of the model that needs to be understood and fully developed. So sorry to interrupt you there, Vinod.
No. I think that was dead on. I struggle with this because I've got patients, disadvantaged patients that change cell phones every month. They have a different phone number every month because they keep hopping between cell phone plans to find the best deal. I've got patients that, during COVID, they were sharing Wi-Fi with their kids going to school because they couldn't afford a higher bandwidth. So we were doing telemedicine and they had to pick between seeing their physician versus their kid going to school. So how do we get this technology? We published a paper. We're submitting a paper right now looking at advanced technologies based on safety net hospital status. And as you would expect, we're not seeing a plethora of robots landing in safety net hospitals, but we are seeing them in well-resourced hospitals. So we're not capturing the data from these disadvantaged populations, but at the same time, this stuff's not cheap. So how do we marry this together to ensure that we're not going to penalize patients because they would simply color their skin or the timing of their birth or what have you?
Yeah, I mean, I'll just kind of talk on that. It's a pretty complex question, but I think, the last thing we need to be doing in terms of AI here and building models, and this is a little bit of the spirit of the paper, is to ask the wrong question of saying, who's going to have a poor outcome, and then how do we, kind of choose the right surgery for that, hypothetical patient, right? So if the worst way to kind of go about it is to say, okay, exactly the patient you described or the disadvantaged patient, they're going to have a worse outcome in our contemporary healthcare environment for multiple reasons: lack of access to technology, lack of access from a surgical standpoint of what we can give them in their hospitals, and then on the back end. So if we ask the wrong question and say who's going to do poorly, and then how do we give the right surgery to them, they're going to be further disadvantaged. So that's kind of a heart of what we're trying to get at here and trying to elicit from a call to action, so to speak. But I would say, it's challenging because we are also trying to be fair and then start extrapolating data and saying, okay, if this patient fit is a twin or kind of it fits our model to match other folks, even if they've not had robotic surgery, even if they didn't get to interface with a doctor preoperatively, if they go through a certain treatment phase or have, total knee replacement, this may be their expected outcome based on, different risk factors going to surgery or how optimized they are. So I think it's going to be a lot of extrapolation and kind of building those robust models to then start predicting how that patient will end up turning out, but not asking the other way around and saying who's going to do poorly and how do we afford those resources to them.
Yeah, I think just to add on that, Atul, I think where we can sort of build our models to be robust to missing data and to be able to output something, I guess, still something that is of value to a clinician or a patient when we do have a partially complete data set. I mean, one And one area that it's a bit sort of tangential to the fairness topic, but in different regions we have different sort of different guidelines and regulations around like data that we can collect and how we're able to collect it and so on. So already in some of the applications that you've seen, we build those models so that they still give a useful insight to clinicians based on partially complete data. So I think for some of the, if we're thinking about underserved populations and the fact that they won't be, as you say, they won't be having a robotic procedure, they're not going to be having the sort of the instrumented implants or whatever, but there's still insight from what data that we can collect from them that can still help them, and I think that's the key is help them towards hopefully a better outcome.
And Vinod, we are in our contemporary kind of environment right now, challenged by a lot of kind of the data pieces between institutions, right? So I think Zimmer Biomet, has done a great job of trying to have a back end piece where we're collecting data and then kind of feeding it back in these types of models. But it is challenging, even in our own institution. It can take a year plus just to get some data agreement in place. And I think when your institution or institution in California, wherever it is trying to then be responsible to add data in, it's our institutions that are, there's barriers and there's other ways. So there's other things that I think we need to kind of grow towards, in terms of that data sharing. That's a huge hurdle in terms of building some of these in-house models versus kind of externally validated models as well, which is an extreme challenge. Yeah.
Carl, are you able to bring in data that's, obviously the ZB technology platform is capturing its own data set. Are you able to marry that with let's say there's a hospital that's got all their EMR data and they take care of an underserved population. Let's pick on Dr. Kirschenbaum's hospital in the Bronx. Let's pretend they don't have any technology. Are you able to marry what you're capturing with ZB with existing data sets in EMRs and things like that? Or are you actively trying to go get that data to have a more representative patient sample? Or is it whatever ZB is capturing, we're just going to make the best of it?
Yeah, so we are looking at, and I think we've had some recent product development where we are looking at EMR integration and being able to sort of interface with those data sources. I think the challenge also, I'm sort of stepping a bit outside. It's towards the commercial side, a bit outside my comfort zone here. But I think the challenge is more about getting sort of agreements in place with various, as you say, this isn't one size. Oh, we could just integrate with any sort of EMR in any hospital across the states now. But we do recognise that. I think we've done it well. Having been part of the team for the last couple of years, the team's done a great job in sort of building out that sort of data position internally. But it does, in terms of what we collect as Zimmer Biomet, but it does have its limitations. I think sort of understanding some of those sort of high value clinical outcomes as well is something that we're looking to do more of, and that's where sort of integrating with hospital systems can come in. So it is part of our strategy, and we do have we've got some recent developments in that space, but it's not a kind of silver bullet that gives you the sort of full access, as I'm sure you can appreciate.
Yeah, no, I wish they would, but obviously there's a lot of landmines there.
Yeah.
Dave, I have a quick question. So, we're talking about health disparities and SDOH and things like that, but I want to ask a couple questions around kind of cultural sensitivity. So I've got, let's say, a 50-year-old construction worker, and let's pretend I do a knee replacement. I've got all these patients, they have the same amount of flexion, their gait cycle is the same and all this kind of stuff. Person's a 50-year-old construction worker. Another person's an 80-year-old lady that just wants to play bingo all day. I've got another lady who her expectation and goal is to be able to kneel and pray 5 times a day. So how does AI take into account this kind of, aside from the physical parameters that we can measure and things like that, how do we account for these varied patient characteristics of who defines what success is?
Yeah, the functional demand, right? That's something I think we're we're actively, actually one of the good things I think about the data that we've collected thus far is it steps outside of just proms and prom collection, because those particular activities that you mentioned and the expectations of those patients, they may not be captured in a pretty typical prom either. I know that CUS-JR is only going to capture the top 7, and it's just going to have to kind of guess at the rest of those kind of functions. But the opportunity that we have to be able to put in gait quality, have some understanding of symmetry, at some point in time, we're very acutely looking at how we can continue to implement range of motion and instruments like Persona IQ. We're taking steps in that direction. The functional demands, I think, as we get better at data collection and surveying patients and collecting some of those preoperative expectations and postoperative functions, I think it gets better over time. Today, in the current situation and setting, I think we have to start with the things that are easy to collect. And for us right now, it's gait, it's gait quality, it's gait speed and asymmetry, and as Dr. Kemp mentioned, the quantitative measures of step counts and things of that nature. So, I think your point is well taken. We have to find ways to continually tailor this to these fringe cases and saying, okay, not everybody is going to be satisfied with just a particular gait speed at 90 days or, gait quality at 90 days. There's different functions that these people are actively involved in. And we're working on, how do we phenotype these patient populations? How do you start to say, okay, with the 80-year-olds or the 50-year-olds, you start with your age and your BMI and some of those kind of characteristics. But then you have to find ways to kind of tailor to activity level, pre-op levels, pre-op activities, post-op, expectations. So data collecting in that space is going to grow. It's going to be, a continual challenge. That's something that we'll probably always have to figure out, what's the next best thing to create in terms of capturing that data.
And I think as clinicians, industry and these models need to be built with clinicians kind of driving a lot of kind of understanding of how this works, right? So your patient who prays 5 times a day needs high, deep knee flexion, has other sort of kind of parameters that needs to be clinically translated, right? That also then has to be mated to things like, we have wearable technologies, we have computer vision technologies, we have understanding, if we can capture or characterize how that patient behaves or acts or lives their daily life preoperatively, beforehand, we can then start adding that into the phenotype or matching them to the postoperative models. So, a priori, we have no idea that this lady kneels 5 times a day and needs deep knee requirements. But we can quickly try to understand that, learn that, and then again, involve the patient perspective, because it's from the patient's end, we don't have those types of questionnaires to start interfacing. So it's a combination, but there has to be a very, big continuous clinical piece to kind of start understanding how to translate that into models postoperatively. But that's an excellent question, Vinod, as well. Yeah.
Got for any of the attendees, if you have any questions, comments, please put them in the chat. Russell, I think you're chomping at the bit here. You want to unmute yourself and tell us what you're thinking? You there?
Yes, I'm here. Can you hear me?
Yep, we can hear you.
I've been listening to this, and I've thought of this for a long, long time. And I think that, as I said there, that if you have a robust profile of a patient preoperatively, I think you can pretty much, this is what AI is built for, predictive of outcomes. So by the time the patient is ready to go to surgery, you could say, you're in this category. You have a 58.8% chance of breaking your bundle. You have a 58% chance of this kind of complication or that. Those are the things that I think, from my perspective, are very valuable. My answer to the patient getting in trouble because they're not taking enough steps postoperatively is see your patients more frequently than 6 weeks and 6 months. Follow your patients. That may be an old idea, but that's how, and allow them to communicate with you. So, I mean, this talk is on how to leverage AI to its greatest degree for me, because you can put it almost anywhere you want. And this is the part of the ecosystem that I think has the absolute biggest bang for the buck for using and calculating all these factors to come up with risk profiles, characteristic profiles, for patients.
Great. Thanks, Russell. Yeah.
Yeah, I can think.
You guys, any comments?
I was just going to add, and I think that all those questions and those those use cases at at sort of the front end and sort of in that pre-op assessment phase, Russell, as you mentioned, there's, as you say, there's huge potential there, and the team talked about potentially sort of clustering patients into different groups to understand what a good outcome looks like for them. I guess from a fairness perspective, the challenge is making sure thinking about right, and what then does if you've developed a product in that space, like what then does a user, like whether it's a clinician or clinical decision maker, what do they then do with that information? Because I think the trade-off is that preoperatively, that's where it's obviously there's more decisions to be made at that point, in terms of like what a patient's eventual sort of episode of care looks like. So it's making sure that that data and those insights that, as you say, the potential is great, and making sure that it's being presented in the right way, to make sure that sort of fair and equitable decisions are being made.
It's more difficult, I think, in the pre-op because it's way more complicated, and the post-op, I think, lends itself to product development, and that's why there's sort of a push towards the product development, because that gives a return on all the work that's done. But I think in the long run, the pre-op is going to be where the gain of an ecosystem and artificial intelligence is. It's just hard, and it's more data driven. It's not so much product driven. And once you have these classification systems, these silos you can put patients in, then doctors have been pretty good at figuring out what to do with these different silos, and they can write lots of papers if we tried this and this and this on this page. And I think that's where it's gonna lead to.
Great, thanks, Russell. We got probably time for one last question. David, you want to ask your question?
Hey, thanks everyone. This has been really eye-opening. My question was kind of how do we prevent machine learning algorithms in general from becoming gameable? For example, if I'm a hospital system and I'm using this financially, and I think that in the future, artificial intelligence is something that's going to be able to predict how much I'm going to be able to receive for a patient billing wise. And the worse their expected outcomes are, the better their expected outcomes are, that's going to change my reimbursement. How do we prevent that from being gameable? And then on the flip side, with us as orthopedic surgeons, there's a lot of subjective measures that are kind of bunched together and put into an objective data point. And how do we prevent those from being gameable in terms of comparisons of different hospital systems and different surgeons to each other?
So, Carl, I'm going to put my iPhone on my dog and run them around the park there. So that way their gait cycle is...
Could happen.
Interesting, yeah. Yeah, well, we've half joked about that scenario, internally. Yeah, it's a great question. I think, I guess a couple of things spring to mind. So I think the first thing, I think part of this is actually it's a design problem, and there is a data aspect as well we talk to. But I guess what the scenario you've talked about there is where you've got different stakeholders in your in your system who have, very different goals. As you said, we got sort of one side that's trying to minimize costs versus, it's not at all in the patient's interest to minimize costs. What they're interested in is their own outcomes. So I think when designing and evaluating sort of machine learning systems, it's important to think about different metrics of performance. So don't just think about, oh, I'm going to minimize cost, but when I'm designing my model, what's the sort of solution or the model configuration that balances those things off? And there's a all sorts of different metrics that you can use to evaluate machine learning models. So I think having multiple different ways of evaluating your model, I think, is important there. And then also, I've mentioned it before, but validating your model on population subgroups is really important. You might have a model that achieves 95% accuracy or something like that, but you might see, if you break it down on different population subgroups, you see that one group is being massively served significantly better by this algorithm than another, so that you can start to sort of understand, actually, what is it about this group that means my model's not performing well? So I think those two things in concert can help to address but it is, and Dr. Kamath's mentioned it already, these are like, they're data problems, but they're also like design problems. And so I think working closely with users and getting feedback of all the different stakeholders involved who are touching these products is critical as well.
Yeah, this is a great question, David. I know we're pretty close on time. This is probably another hour of all discussion in and of itself, but I think we're obligated, right? There's going to be a little bit of a data arms race between payers, insurance companies, healthcare systems, to start looking at the same types of questions, but answer, same data and asking different questions from a different frame of reference, right? And we're obligated to stay on top of this, and then to really understand, how do we create environments that our patients can succeed in, rather than chasing a specific metric like step count or cost per case or something. We're really starting to look at how do we optimize, identify, and maximize and show the utility of our surgeries, right? It may sound a little naive from that perspective, but we do have to push our own agenda in terms of looking at the data from an as unbiased perspective as possible, and then protecting and asking the right questions that are not simply through the lens of, okay, how do we penalize someone for having poor outcomes? So again, it's kind of a big topic, but you really, enjoy, hearing from you on that question as well.
All right, guys, we're up at the top of the hour. I think we probably, like you said, keep talking for about a week on this. We've got a lot to learn and a lot to do. So I'd like to thank everybody for your time. Hopefully everyone learned something here. I know I did. And stay in touch. If you want to reach out to the authors, we've got a group on Doc Social. If you go to the group section in the JOEI group, you can put some chats there and connect with some of the authors if they're there. Otherwise, reach out to any of us, Dr. Kirschenbaum, myself, and keep the conversation going. So with that, thanks everyone for your time. Have a good night and take care.